Good afternoon. I'm Commander Abad Khan, and I'm representing the Clinician Outreach and Communication Activity COCA with the Emergency Risk Communication Branch at the Centers for Disease Control and Prevention. I'd like to welcome you to today's COCA Call, Telehealth and Health Equity, Considerations for Addressing Health Disparities During the COVID-19 Pandemic. Free continuing education is offered for this webinar. Instructions on how to earn continuing education will be provided at the end of the call. In compliance with continuing education requirements, CDC, our planners, our presenters, and their spouses, partners wish to disclose they have no financial interests or other relationships with the manufacturers of commercial products, suppliers of commercial services, or commercial supporters. Planners have reviewed content to ensure there is no bias. The presentation will not include any discussion of the unlabeled use of a product or a product under investigational use. CDC did not accept commercial support for this continuing education activity. At the conclusion of today's webinar, participants will be able to accomplish the following: discuss CDC's COVID-19 health equity strategy and implications for health services, describe how telehealth can bridge health equity gaps and expand access to care during the COVID-19 pandemic, and discuss telehealth utilization and implementation experiences for under-resourced communities. All participants joining us today are in listen-only mode. After the presentation, there will be a Q&A session. You may submit questions at any time during the presentation. To ask your question using the webinar system, click the Q&A button at the bottom of your screen, then type your question in the Q&A box and submit your question. A video recording of this COCA call will be posted on COCA's webpage and available to view on demand a few hours after the call ends. If you're a patient, please refer your questions to your healthcare provider. For those who may have media questions, please contact CDC Media Relations at 404-639-3286 or send an email to media@cdc.gov. I would now like to welcome our presenters for today's COCA call. We are pleased to have with us today Dr. Leandris Laborde, who's the COVID-19 Chief Health Equity Officer and the Director of the Office of Minority Health and Health Equity for the Centers for Disease Control and Prevention. Dr. Kendra McDowell, who is an epidemiologist with the Health Systems and Worker Safety Task Force for CDC's COVID-19 response, and Dr. Kemi Ali, who's the Chief Executive Officer at the Henry J. Austin Health Center. I would now like to turn it over to Dr. Laborde. Dr. Laborde, please proceed.
Dr. Laborde might be on mute. Dr. Laborde, can you check your mute button, please, ma'am?
Is our Zoom host able to unmute Dr. Laborde's line remotely, please?
Unfortunately, I'm unable to unmute Dr. Laborde at this time.
Good afternoon. Can you hear me now?
Yes, Dr. Laborde, we can hear you. Thank you so much.
Okay, thank you. Again, good afternoon, everyone, and I'm so excited to be partnering with you today. As was already mentioned, I'm Dr. Leandris Laborde, and I currently serve as the Chief Health Equity Officer for the CDC COVID-19 response. And when I'm not in the response, I serve as CDC's Associate Director for the Office of Minority Health and Health Equity. And in this role, I lead a wide range of critical functions in the agency's work in minority health and health equity, women's health, and diversity and inclusion management. CDC continues to accelerate progress toward reducing COVID-19 disparities and achieve health equity. And today, I'm going to take some time to talk about how CDC will work with jurisdictions to achieve the objectives, activities, and outcomes of the COVID-19 health equity strategy. As this audience well knows, COVID-19 has exposed decades of inequities that have systematically undermined the physical, the social, material, and emotional health of racial and ethnic minority populations and other population groups that are bearing a disproportionate burden of COVID-19. And this includes, but is not limited to, people who experience homelessness, people with substance use disorders, those who are justice-involved populations, and people with disabilities, as well as persons not born in the U.S. Next slide, please. So before I introduce the CDC COVID-19 health equity strategy, I always think it's a good idea just to ensure that we are grounded by at least two key definitions, one of health disparities and the other health equity. I think it's important to note that health disparities are not just a difference. If you could go back, thank you, yes. The health disparities are not just a difference in health outcomes between population groups, but we define health disparities as a particular type of health difference that is closely linked with social, economic, and/or environmental disadvantages. And health disparities have historically adversely affected groups of people who have systematically experienced greater obstacles to health. And I'll say a little bit more about that in a minute. We are working, though, to achieve health equity, which we define as when everyone has the opportunity to be as healthy as possible. And this is accomplished, first of all, when we value everyone equally. The definition that we have here is one that we borrowed from the Department of Health and Human Services. And the subtext, I think, is particularly important in that it says that in order for us to achieve, and for individuals to attain their highest level of health, we must value everyone equally with focused and ongoing societal efforts to address avoidable inequalities, historical and contemporary injustices, and the elimination of health and healthcare disparities. Next slide, please. So as we continue to learn more about the impact of COVID-19 on the health of different populations, immediate action is critical to reduce growing COVID-19 disparities among the populations known to be at disproportionate risk. So since May, we have been diligent in our efforts to raise awareness and mobilize action to address these disparities through the Chief Health Equity Officer. Next slide, please. So now I'm going to just take a few minutes to talk through, at a very high level, our health equity strategy. We have 4 strategic priorities to reduce the disproportionate burden of COVID-19. And CDC intends to continue to partner with physicians, epidemiologists, public health practitioners, and state and local health department officials to implement the health equity strategy in a number of different ways. Strategy 1, you'll see, is to expand the evidence base. We know it's critical to collect and report timely, complete, and relevant data on testing, incidents, severe outcomes, and eventually vaccination by race and ethnicity. Case-based reporting is critically important to the response, and CDC is committed to working with state and local health department officials as we continue to improve the overall completeness of case reporting from 21% when we started to 60% now for race, and from 18% to 50% for ethnicity from April to August 2020. So we are making progress. We recognize demographic data can be challenging to gather for some focused populations, such as people with disabilities. So as a result, CDC may explore special studies and other surveillance systems to gather stronger and more actionable data. Our strategy number 2 is to expand programs and practices for testing, contact tracing, and healthcare in order to reach populations that have been put at increased risk. We are identifying and establishing collaborations with critical partners aligned with place-based settings that serve and support populations at increased risk for COVID-19. As a result of these collaborations, we expect to build community capacity to reach disproportionately impacted populations with effective culturally and linguistically tailored programs and practices for testing, contact tracing, vaccination, and healthcare strategies. We also will establish collaborations with critical partners aligned with place-based settings, as I mentioned before, and also identify partnerships with state and local policy organizations to develop evidence-based strategies for preventing COVID-19 among populations placed at highest risk. Strategy 3 is to expand program and practice activities to support essential and frontline workers. And we are developing health communications with culturally and linguistically responsive materials. We are promoting scientifically accurate information on the prevention of COVID-19 and the importance of wellness visits tailored to frontline and essential workers. We are also supporting capacity building for vaccine distribution and administration to frontline and essential workers by establishing partnerships with organizations, including federal, state, and local agencies, private sector partners, including healthcare practitioners and community-based organizations. And finally, for strategy 4, we will expand an inclusive workforce that is equipped to address the needs of an increasingly diverse U.S. population. CDC is building a diverse responder workforce to represent the racial, ethnic, and social backgrounds of an increasingly diverse U.S. population. We are leveraging the multidisciplinary, multilingual, and multi-generational makeup of the public health workforce and leveraging them to engage with the COVID-19 response. Next slide, please. So it's important to consider factors that influence access to medical care during COVID-19. Things like inadequate health insurance coverage is a major barrier to medical care, and unequal distribution of coverage directly impacts health disparities. Also, unreliable transportation plays an integral role in persons having difficulty accessing health care. A lack of transportation leads to patients, especially people at increased risk of severe illness from COVID-19, from missing medical appointments and delaying medication. The use of stigmatizing language in medical practices and materials and limited access to medical resources are additional barriers that contribute to reduced access. Next slide, please. So what can we do? We all have a part in helping to prevent the spread of COVID-19 and to promote the fair access to health that's needed by all in our citizenry. To do this, we have to work together to ensure that people have resources to maintain and manage their physical and mental health, including having access to information, affordable testing, and medical care. We need programs and practices that fit the communities where people live, learn, work, play, and worship. A few actionable steps that we can take include training employees at all levels of the organization to identify and interrupt all forms of discrimination, to provide them with training in implicit bias, Also, increasing engagement with trusted community and faith-based organizations and institutions that have relationships with local communities, and providing telehealth options that are tailored to the needs of patients. Ensuring that chronic disease management and services to prevent illnesses are maintained and accessible, and providing patient supports like reminders and self-care management programs, and helping people understand what contact tracing is and why public health workers need to find people who have come into contact with someone who has COVID-19 and what successful contact tracing requires. Also addressing misunderstandings about why people are being asked for personal information and why this information is important for stopping the spread of COVID-19. A longer list of actions can be found on CDC's COVID-19 webpage for health equity under What We Can Do. Next slide, please. So in closing, I just want to encourage you to learn more about the Chief Health Equity Officer's Unit, about health equity and the COVID-19 health equity strategy by visiting our webpage. And as I close, CDC continues to facilitate partnerships between public health practitioners, state and local health departments, public health agencies, scientific researchers, professional organizations, and community organizations to share information and collaborate to prevent COVID-19 in communities placed at higher risk. Today, I welcome new opportunities for collaboration and feedback, and I will now hand over the presentation to Dr. Kendra McDowell. Thank you.
Thank you, Dr. Leandris. Next slide, please. Good afternoon, everyone. As Dr. Leandris mentioned, my name is Dr. Kendra McDowell. I'm a pediatrician and epidemiologist leading the implementation and telehealth unit within CDC's COVID-19 response Health Systems Worker Safety Task Force. Next slide, please. In this presentation, we will describe telehealth utilization in the context of health disparities and under-resourced communities, examine the importance of using telehealth to provide continuity of care to reduce negative consequences in populations disproportionately affected by COVID-19, present telehealth limitations in the context of health equity, and identify potential solutions to telehealth limitations that increase utilization and optimize telehealth experiences in groups at higher risk of negative outcomes during the COVID-19 pandemic. Next slide, please. The COVID-19 pandemic has resulted in rapid changes to care delivery models with increased adoption of telehealth by providers and health systems. Recent changes have reduced barriers to telehealth use to promote expanded access to medical care. Telehealth also functions to facilitate public health mitigation strategies, reducing healthcare worker and patient exposures. It can help preserve PPE, better known as personal protective equipment, and reduce patient surge on healthcare facilities. Telehealth also provides opportunities for data sharing to improve surveillance and collaboration. We specifically recognize that telehealth in the context of the COVID-19 pandemic can contribute to health equity by increasing healthcare access for groups that have been socially marginalized in populations with chronic or complex medical needs by maintaining care continuity. Next slide, please. During the COVID-19 pandemic, racial and ethnic minorities have been disproportionately impacted, with increased rates of infection, hospitalization, and mortality due to COVID-19. Long-standing systemic health and social inequities have contributed to racial ethnic minority populations being disproportionately affected by COVID-19. Rural communities may also be at increased risk of severe outcomes from COVID-19 illness due to less access to health care and health insurance coverage compared to urban counterparts. Findings from a recent MNWR found that rural counties have a higher prevalence of medical conditions associated with increased risk of severe illness from COVID-19. Telehealth can provide continuity of care during the pandemic. Telehealth maintains and expands care for under-resourced populations by removing barriers such as transportation, missed work and school, childcare, and limited access to subspecialty care. Illustrative of the value of telehealth in maintaining care continuity are findings from the New York Presbyterian, Columbia, and Weill Cornell Pediatric Weight Loss Program, which serves a predominantly low-income and racial and ethnic minority population. In March, the Pediatric Weight Loss Program transitioned to virtual visits. With reduced barriers to participation due to telehealth, the program's show rate increased from 55 to 65% pre-pandemic to 76 to 89% after the transition to telehealth in March and April. Next slide, please. As mentioned, there are opportunities for telehealth to improve access to care and facilitate public health mitigation strategies. We recognize that there are limitations to telehealth and that telehealth may not be optimal for situations in which in-person visits are more appropriate due to urgency, underlying health conditions, or inability to perform an adequate physical exam, or privacy cannot be maintained. Other limitations include limited access to technological devices needed for an optimal telehealth visit or connectivity issues. The level of comfort with technology for healthcare personnel and patients, as well as the cultural acceptance of virtual visits. We will look closer at these two limitations later in the presentation. We also recognize that people with disabilities may experience unique challenges, specifically related to effective communication and physical assessments. For example, persons with mobility or manual dexterity disability may have difficulties interacting with the telehealth platform or remote monitoring devices. Next slide, please. It is of critical importance to understand both the opportunities and the limitations of telehealth. Utilizing a health equity strategy in the development and implementation of telehealth services helps ensure that the expansion of telehealth does not unknowingly create or widen health disparities. Multiple telehealth limitations have the potential to exacerbate disparities, including, as we move left to right, digital health literacy. Studies have shown that digital health literacy is influenced by socio-demographic factors, and individuals with higher digital health literacy proficiency have more success applying information for management of healthcare needs and healthy behaviors. Conversely, low digital health literacy may limit a patient's ability to benefit from expanded health services provided through telehealth. Access. Access to technological devices and broadband internet is essential for a successful telehealth visit. However, access may be dependent on geographic location and socioeconomic status. People with disabilities may face multiple access challenges in addition to disparities in access to broadband internet. Healthcare infrastructure. A healthcare system's approach to telehealth implementation can impact health disparities. Considerations include having the physical and human capital resources to successfully implement telehealth. Furthermore, it is important that telehealth services are available across all healthcare institutions, especially those that serve a disproportionate number of individuals with disabilities. The telehealth platform. It is important to use an inclusive platform with intuitive navigation and enhanced privacy settings. Non-inclusive telehealth technology can create barriers to use, for example, individuals with disabilities or non-primary English speakers, and may result in disparate patient experiences and health outcomes among economically or socially marginalized groups. Lastly, patient distrust. Distrust between the healthcare system and the patient may result from groups' experience with the healthcare system, stemming from provider or health system implicit biases, lack of cultural competence, or history of discrimination and racism, and may influence telehealth utilization among certain populations. Next slide, please. Let's take a deeper dive into the digital barriers that can potentially exacerbate differences in health outcomes when implementing telehealth for under-resourced communities. Many Americans have broadband, high-speed internet, and smartphone access. However, access varies by age, race, ethnicity, education, disability status, income, and location, with older adults, Hispanic adults, those with high school or less education, and adults with low income having lower access to home broadband. 79% of suburban areas have home broadband compared to 63% of rural areas. As we can see, some populations with less access to home broadband have also been found to be disproportionately impacted by COVID-19 and would most greatly benefit from telehealth services. Access to high-speed internet allows for participation in virtual visits, transmission and access to health information, and use of remote monitoring technology. Next slide, please. In the setting of existing barriers to telehealth implementation, rapid adoption and scale-up of these services may limit access to care for under-resourced populations, potentially resulting in disparities in health outcomes. After the University of California, San Francisco primary care clinics scaled up telehealth service in mid-March, increasing telehealth from 3% of total visits to 80% of total visits. As we can see on the left-hand side of the slide, the proportion of visits, telehealth and in-person, by older adults, non-English speakers, and patients with Medicare and Medicaid significantly decreased. A recent Health Affairs article illustrates the importance of centering health equity and the needs of populations disproportionately impacted by COVID-19 when developing and deploying telehealth services. In the article, Dr. Kamara Sundar recounts caring for a woman with COVID-19 who was unable to self-isolate at home due to crowded living conditions and was staying in a storage unit. The woman did not have a smartphone to schedule a telehealth visit or view the clinic's web resources. Dr. Sundar writes, "It became clear that our virtual first strategy was neither available nor accessible to my patient. In fact, it wasn't accessible to anyone who didn't have reliable internet access, didn't have the right technology, or didn't have the digital literacy to sign up for our virtual platform." Next slide, please. Despite these limitations, healthcare systems and clinicians can develop actionable solutions to improve telehealth access and quality by analyzing telehealth utilization data to identify potential access gaps, adopting innovative strategies to mitigate digital health literacy barriers and barriers to people with disabilities, and assess the patient's medical, technological, cultural, and linguistic needs before a telehealth visit to ensure an optimal experience. Next slide, please. Healthcare systems and clinicians can take steps to improve health disparities using telehealth services through patient advocacy, offer telehealth visits to all patients, establish programs to acclimate patients to telehealth visits, set up digital health literacy programs, and provide outreach to patients with digital barriers. Provider training. Ensure provider training with the telehealth platform prior to use. Ensure providers show awareness of and respect for culture when providing care, and consider how biases may develop or evolve when providing virtual care. Operationalization of telehealth workflows. Create workflows to facilitate optimal telehealth visits. Use platforms that have been tested across social demographic and digital health literacy spectrums, as well as by people with disabilities, so that it can be used by diverse patient populations. Quality metrics. Define telehealth utilization and patient outcome metrics to assess telehealth care quality and identify potential gaps. And lastly, collaborate with community-based organizations and partner outreach. Collaborate to promote digital health literacy and telehealth, along with development of policies that expand digital access and resources. Next slide, please. Federal, state, tribal, and territorial governments have also developed innovative strategies to improve telehealth access and utilization and decrease technological barriers. The Federal Communications Commission, also known as the FCC's Lifeline program, provides a monthly wireless and broadband service discount to people with low income. The FCC's Lifeline is available in every state, commonwealth, territory, and on tribal lands. During the COVID-19 pandemic, a waiver is in place to prevent involuntary de-enrollment from the program. Washington State developed the Drive-In Wi-Fi Hotspots program to provide free temporary internet access to individuals without home broadband access. The program was launched in response to the COVID-19 pandemic, and there are currently 300 hotspots in rural communities and low-income urban and suburban communities. Next slide, please. In conclusion, telehealth is an innovative healthcare delivery model with the opportunity to expand medical care access and facilitate public health mitigation strategies during the COVID-19 pandemic. In the rapid expansion of telehealth services, we cannot create, reinforce, or widen health disparities for some populations. Grounding telehealth in health equity and centering socially and economically marginalized groups in the development of actionable solutions may help reduce COVID-19 related health disparities and increase healthcare access in populations disproportionately impacted by COVID-19. Next slide, please. We have some resources here and also additional telehealth resources that are available on the CDC telehealth webpage and COCA Call webpage. I would like to thank you so much for participating in this COCA Call. And also, before I transition the presentation to Dr. Kimmy Ali, I would like to thank the team members of the Implementation and Telehealth Unit, especially Erica Tyndall for assistance with preparation of these slides. Thank you so much. Next slide, please. Thank you. I can transition to Dr. Ali.
All right, good afternoon, everyone. As mentioned, I am Dr. Kemi Ali. I'm the CEO here at my health center in Trenton, New Jersey. I want to say that I'm equally excited to be speaking with you this morning and thank those for the invitation. So next slide. In my discussion today, I'll go over a few of these. I'll go over these topics. Who are we at Henry J. Austin? I'll also talk about how we implemented telehealth and where we are now to give that sort of snapshot of where we are on the ground in the front line. And then discuss some of the challenges and also some of the opportunities, and also what we see as the future of telehealth, particularly in our community. And as I do so, I think you will hear an alignment of themes that have been talked about by Dr. LeBird, as well as in particular by Dr. McDowell. It's almost as if we read her presentation as we started our implementation process. So I'm very validated to see that our processes really are steeped in that evidence-based knowledge. Next slide, please. So who we are at Henry J. Austin. We are a federally qualified health center. We've been providing services to our community for 50 years. And as I mentioned, we really take pride in using evidence-based technology and services and processes whenever we can, as well as leaning upon what's best practice and being innovative all at the same time. And sometimes it's a little bit of a balance to be evidence-based, but also be innovative. But we take that very seriously at Henry J. Austin. As such, we are both Joint Commission accredited, and we are also Patient-Centered Medical Home certified. We've been recognized by the Health Resources and Service Administration for enhancing access to care, reducing health disparities, and also advancing quality through health information technology. Next slide, please. So we have 4 standalone sites, so they're the very traditional bricks and mortar buildings. We also have 3 sites that are embedded within mental health institutions and 1 within a homeless shelter. And we have a mobile health unit as well. We serve about 30,000 active patients that generate about 70,000 visits a year. Next slide, please. When you look at our demographics of our patient population, 1 in 9 are experiencing homelessness. Over half of our patients are African American and or female. 1/3 are Latino, and 2/3 of our patients fall 200% or more below the federal poverty level. Next slide, please. We're also very proud that we have some unique partnerships, and one of them is the Trenton Health Team. So this is a non-profit collaborative that was started in 2012 between Henry J. Austin, our 2 local hospitals, and the city of Trenton, represented by our Department of Health and Human Services. And this nonprofit was formed really with the goal of making Trenton the healthiest city in the state. And it was unique in that these competitors, because basically we're competitors, local hospitals, Henry J. Austin and the City Department of Health, came together understanding that we are stronger together and really forming this collaborative nonprofit, pooling our resources and manpower and strengths in order to improve the health and well-being of our Trentonians. Next slide, please. So when we look at particularly telehealth, and much of what I talk today about will be through this lens of how do we implement telehealth through this lens of equity and identifying those gaps and overcoming that. And as I mentioned in the first slide, this idea of reducing health disparities is really important to Henry J. Austin. And so we, right from the get-go, we were really looking at how we implement telehealth and not increase those inequities and not increase disparity, as Dr. McDowell had mentioned in her presentation. So we'll talk about people, process, and technology as we implemented telehealth. Next slide. So the people. Next slide. So when you look at the people within your organization or our organization, one of the things we did from the beginning is said, what are the unique roles we want our staff to have in providing patient support and guidance, understanding that there is inherent inequities within our system as it stands today. And as Dr. McDowell said, we don't want to exacerbate those. We don't want to make it worse. And so one of the first things we did is we took our staff and we divided them into teams and identified their roles in providing that additional support and guidance that's necessary. Next slide, please. And so when we looked at our structure of individuals we have within our organization that surround our patient and wrap them with services, as you can see, there are many people and many different functions and roles within our organization. We have providers, behavioral health counselors, clinical pharmacists, we have peer support specialists, we have scribes, and then we have those that I highlighted in green that I'll really spend a little bit more time talking about in terms of medical assistants, nurses, community health workers, and receptionists. So next slide. So we took a deep dive, as I said, looking at our people and identifying how they are uniquely positioned or have the skill set to fill some of those gaps in order to reduce some of those inequities. So whether it was our medical assistants that had a role of engaging patients, or our unit receptionists that called ahead to confirm the telehealth visit, or whether it was our nurses really ensuring that patients had access to the systems that were needed. They each had a role and it was defined within our system. Next slide, please. So this was that flow chart, and I think this is exactly what Dr. McDowell was mentioning in really looking at your workflow, looking at our processes and identifying where there might be gaps and how we were going to use our staff, use our people to fill those gaps and hopefully not increase any inequities. And again, with the overall goal of reducing disparities. So whether that was our call center team that reached out to patients ahead of time to facilitate that telemedicine visit, or whether it was a medical assistant who called the patient after the visit to make sure that they really understood and that they had clear engagement with their provider and all their needs were addressed. So this was really an important step for us. Next slide, please. So let's take a look at the process itself. So next slide. When we think about the process of implementing telehealth, and again, with this lens of not wanting to increase inequities, really wanting to reduce health disparities, some of the things we needed to think about is how are we communicating with staff, but also how are we communicating with our patients? What is the platform that we are going to use, as was mentioned again in the previous presentation? What's the platform that we're going to use? What's the platform that's the most accessible to our patients? What's the technology we want to think about here? And so whether that was Zoom phone or Google Voice or some of the other tools that were out there, we wanted to really assess and make sure we had a tool that was going to meet the greatest need, both for our patients as well as our staff. Next slide. And then we also had to think about, when we're thinking about our processes, how are we going to share documents between staff, but also between patients? Because a lot of what we do in a visit is share information, physical information, whether it was something that a patient needs to sign or something we wanted to hand to them after the visit. How are we now in this virtual world going to get that to them? And so really thinking through those processes, and sometimes it actually required going to an entity to say, your process requires us to get a wet signature from our patients. We can't do that in this virtual world. Will you accept something else? And again, that requires that proactive thinking and really outlining what the process is going to look like in this telemedicine, telehealth world. Next slide. And then also was mentioned thinking about what are those visits that must be face-to-face. And how do we support our patients through that process? So one of the things we realized, as was mentioned again, was transportation is an issue, is a barrier for our patients. And particularly in this environment was compounded by the COVID-19 pandemic. So what we did was we contracted with one of the transportation car services in our community so that we could help our patients get to the face-to-face visits that were required. And a real big one for us was our COVID testing. And that is obviously a visit that has to be face-to-face. And so once again, we wanted to make sure that our patients could access the system. So again, thinking about those visits that do need to be face-to-face and how are we supporting our patients in that process. Next slide, please. So now thinking about technology. So we talked about the people, we talked about the process. Now technology. Next slide, please. So when we're thinking about technology, we wanted to make sure as best as possible that the platform is accessible. And as such, one of the things we realized is that there are some platforms that require an app. And if you don't have an app, you can't access that telehealth platform. And so very early on, understanding that we wanted to create a technology platform or have a technology platform that was going to provide the most access that we possibly could. So again, using a platform that did not require our patients to have a smartphone or to download an app was particularly important for us. And I say the next point here is something fast and easy, and that was important to us to get up and running as quickly as possible. Again, identifying that we didn't want to have long gaps in accessible care to our patients. And easy, not just for our patients, but also for our teams, because we understood that a lot of our frontline staff are from the very communities that we are serving. And so when we talk about the digital divide and we talk about digital health literacy, we were understanding that our patients and our providers and teams are often from the same community, and we want to make sure that we have technology that is accessible to our patients and our teams. And then also thinking about not everyone has smartphones, so we needed the capacity to have a platform that was audio only and could easily go back and forth between the video visual component and an audio only component. And so that was very important as we looked at what technology we chose. Next slide, please. So where are we sort of now with our telehealth? Well, I will start with saying that we converted to telehealth, as I mentioned, very quickly. Within 3 to 4 weeks, we had converted our entire organization, those 30,000 active individuals, over to a telehealth platform. And we saw that we had really good success. And we believe that success really hindered around those individuals that we called connectors. So those medical assistants, the nurses, the community health workers, the patient navigators, that all had a role in making sure that our patients were connected to the system, that could access the system was really important. And since then, we've seen sustained success with our telehealth platform. Next slide, please. And one of the things that we also thought was really important as we designed our telehealth and looking through this lens of equity is that understanding that our staff are often from the same communities where our patients are from, and therefore have some of the same hurdles to overcome. And so we wanted a system that was flexible and nimble, not just for our patients, but also our staff. And as such, this ability to work from home whenever is required was really important to us as an organization. And we've had no call outs during the COVID pandemic, I think, as a result of being flexible and nimble. Next slide. So challenges with telehealth. So creating efficient workflows, as I said, was really important from the beginning, understanding where those gaps will be and trying to overcome them as best as possible. I won't say that it was out of the gate. We understood exactly what all those virtual workflows would be, but having a process of rapid improvement, so understanding and then being able to assess where you are and make very rapid decisions of improvement was important. Ensuring also governance and community-wide understanding of what telehealth was really important. So one of the things we found early on is that even though we were providing the telehealth visits, there was a misunderstanding that we might have been closed. And so having to really understand that and change our methods, change our marketing strategy so that our community understood what a telehealth virtual visit was and that we really were open to provide those services during the peak of that COVID epidemic. And that took the form, for example, of Facebook Live sessions or Instagram sessions where we really got out into the community and publicized what a telehealth virtual visit was and helping to ensure that our community understood what that meant. Next slide, please. Next slide, please. And as we mentioned before, the challenges with telehealth in terms of those technological or patient technological deficiencies, we embarked on understanding that and then closing that gap as best as possible. And so when we had, for example, our community health workers or our navigators reach out to patients ahead of time, if they didn't have a smartphone, if they didn't have internet access, we ensured that they could use just their phone. We also, with our collaboration of the Trenton Health team, identified hot spots within our community and our organizations so that patients could use those hot spots to go to if they didn't have that technology within their homes. And that was also very helpful. And then, of course, there's a larger conversation of the challenges with sustainable reimbursement. So right now in our state, the governor has an executive order that has allowed for reimbursement of all forms of telehealth. But we understand if that changes, that will definitely change the methods that we use to provide the services. And so that's a challenge. Next slide, please. And so as we look at telehealth, understanding the various opportunities under that rubric of telehealth we think is important. And so we talk a lot about telemedicine today and also telephonic care. So that's what we did a lot of within our health center, both telemedicine and telephonic care. But also there's e-consult, so that asynchronous video conferencing. So again, there are many different opportunities under this rubric of telehealth, and thinking about how can we leverage that to increase access will be important as we go forward. Next slide. So further opportunities as we look for the future of telehealth and how we can expand access for our patients. So I touched upon the transportation difficulties and how thinking about those processes is really going to be important. But can telehealth be a bridge for those individuals, as well as was mentioned, those individuals with disability, but keeping that lens of we don't, again, want to create inequities in the systems. And so being very mindful of what the platforms are that we choose is important. And then also we've been thinking about within our organization, how do we use this telehealth new world for recruitment and retention strategies? So can we offer individuals to work one day at home, for example? Next slide. And so lastly, when we look at the future, we've really been thinking about how do we collaborate with our partners, increasing this access, particularly when we look at that digital divide and having perhaps kiosks located throughout our counties and partnering with our county libraries as ways to really think about leveraging telehealth for the future. Next slide. So thank you very much for this opportunity, and I now turn it back over to Mr. Khan, our moderator.
Thank you so much. Presenters, thank you for providing our audience with such useful information. We will now go into our Q&A session. Please remember, you may submit questions to the webinar system by clicking the Q&A button at the bottom of your screen and then typing your question. We have received quite a few questions, so I'm going to jump right in. Speakers, please identify yourself when you answer a question. Our first question asks, can you please speak to any additional barriers there are for mental wellness services in underserved communities? Do you think telehealth mitigates or can create further challenges to participation?
I will say, this is Dr. Ali. I think it is a fine balance. I think in some regards, it definitely can increase the access. And we have seen that within our organization. Our productivity for our behavioral health providers went up 130%. And so for some individuals, using that telemedicine or telephonic access was very important and crucial. But again, we want to be careful for those individuals that particularly have a disability that may limit their ability to use the technology. And so again, it's that fine balance between improving access and really then being very careful of those individuals where the telehealth may not completely fill that void or that gap, and therefore how do we think about that as we go forward?
Thank you very much. Our next question addresses or inquires about pediatric patient population. Has the COVID-19 pandemic affected pediatric vaccination programs? And what kind of solutions can you recommend to overcome any such lapses?
Hi, how are you? This is Dr. McDowell. What we are kind of seeing in general, I'll get to pediatrics, but in general with adults, there's a recent MMWR that came out on September 10th that found that 4 in 10 US adults are delaying or avoiding, seeking health care. And in particular, the populations that are more likely to delay are kind of populations that we spoke about, those individuals that are caregivers, so adults that are caregivers, individuals that have multiple chronic diseases, and also individuals that are racial and ethnic minorities. We are seeing that, and I'm sure you've also seen this as well in the media, that media reports, and also CDC has MMWRs and scientific reports about this, but that pediatric vaccinations are being impacted by the COVID-19 pandemic. In regards to, solutions around this, it really is, messaging from the healthcare system and provider side, also from public health practitioners, that vaccines are necessary, vaccines are safe and important, especially in your child's life, but especially during this time period, and that the pediatric offices are open and available, and that there are processes in place to make sure that, as we said, through workflows, to make sure that your child and your family are kept safe. So that's something there in terms of solutions. I don't know if Dr. Ali wants to add anything else.
I think you said it very well, Dr. McDowell, because that's exactly what we did. And we in our institution saw the drop. We have, and so right now we do have a group of individuals that need to be immunized that are behind. And we had to do just what you said, is put out educational campaigns, working with those collaborators as part of the Trenton Health team, really getting out the message that we have processes in place. It is safe to come on site. And it really is important that children are immunized. We would hate to have an outbreak of any disease that is preventable within our communities. And so right now we've started a campaign of sort of going back to those days of mass immunizations, where we schedule as many children as possible to come on site and have immunization days over and over, trying to get to that group of individuals that hasn't come in. And again, it's going to be a continued effort to market, to educate, to campaign to our communities that this is safe, and we have the processes in place to make sure that the children stay safe while they get their vaccinations.
Thank you very much. Next question asks, can you please talk about telehealth services that are available, if they are, to incarcerated individuals? And can you share your experiences regarding that?
So we do. So we work with our county correctional facility. And in particular, this was important for us with the opioid epidemic. You know, with the pandemic, it seems all the conversations around the opioid epidemic have gone away, but the opioid epidemic has not gone away. And so it continues. And in fact, it in our community has been worsened by the pandemic. And so we continue to have telemedicine visits with those that are in our correctional facility, and that partnership I think has been made stronger through this process of, again, institutions that weren't readily accessible to telemedicine before the pandemic. Really, this gave that push to really improve the systems, improve the technology so that we could have that telemedicine access. And so that's one program that has been working successfully within our organization.
Thank you very much. Okay, we have time for one last question. And our question states that we've talked about phone lines and broadband and Wi-Fi. What are some solutions that you can share based on your experiences for telehealth when specialized equipment is required for an examination?
So if you think, if the question is about specialized equipment, more advanced equipment, that usually requires the support of a support staff person. For example, ear, nose, and throat doctor may have some specialized equipment to look into the ears or look into the eyes, for example. Those are generally done within a practice setting. So a patient would have to come on site and then have a support person, a nurse or a medical assistant, assist with that process. If you're thinking, if the question is around specialized equipment that could be done from the home of a patient, like a blood pressure cuff or sometimes digital glucose monitors that wirelessly transfer information, then again, the key there is really making sure that the patients, the community has that education ahead of time and that they feel supported and with guidance through that process of using the technology.
Great, thank you. Thank you so much, Dr. Ali. I want to thank all our audience, but especially our presenters for sharing such valuable information. All continuing education for COCA calls are issued online through the CDC Training and Continuing Education online system at https://tceols.cdc.gov. Those who participate in today's COCA call and wish to receive continuing education, please complete the online evaluation by October 19, 2020 with the course code WC2922-091520. The access code is COCA091520. Those who will participate in the on-demand activity and wish to receive continuing education should complete the online evaluation between October 20, 2020 and October 20, 2022 and use course code WD2922-091520. The access code is COCA091520. Continuing education certificates can be printed immediately upon completion of your online evaluation. A cumulative transcript of all CDC ATSDR continuing education obtained through the CDC Training and Continuing Education online system will be maintained for each user. Today's COCA call will be available on demand a few hours after the live call. You can find the video recording of today's call at emergency.cdc.gov/COCA. Please join us for our next COCA call, Testing and Treatment of 2020 to 2021 Seasonal Influenza During the COVID-19 Pandemic. This COCA call will be held this Thursday, September 17 at 2 p.m. Eastern Time. Please continue to visit emergency.cdc.gov/COCA to get more details about this call and others, as we intend to host COCA calls to keep you informed of the latest guidance and updates on COVID-19. COCA call announcements for upcoming COCA calls and other COCA products are sent via email. In addition to visiting our webpage, please remember to subscribe to COCA to receive notifications about upcoming COCA calls or other COCA products and services. Be sure to subscribe to receive notifications by going to emergency.cdc.gov/COCA. Again, that's emergency.cdc.gov/COCA/subscribe.asp. Please share the call announcements with your clinical colleagues. You can join COCA's mailing list by visiting the COCA webpage at emergency.cdc.gov/COCA, clicking on Get Email Updates and entering your email address. To stay connected to the latest news from COCA, be sure to like and follow us on Facebook at facebook.com/CDC Clinician Outreach and Communication Activity. Again, thank you for joining us for today's call and have a great day.